So let's continue with our respiratory physiology. Before we move on to lung volumes, there is some things I wanted to talk about. Let's say there is two spheres. One is big and the other is small. And then there's a clamp in the middle, okay? And neither of the spheres are going to have surfactant, okay? And they have the same surface tension. So what's going to happen if we open up the clamp? What's going to happen if we let the clamp go? If we let the clamp go, then let's talk about it in terms of the equation. So we know the collapsing pressure is 2 times surface tension divided by radius. When the radius drops, in this case the radius is lower than this, the pressure increases, right? So since the radius is low, the pressure is going to increase inwards, and this is going to collapse, making this one bigger in size, but this smaller sphere is going to collapse if we open the clamp, because all the air is going to move because of the surface tension. Same thing is going to happen in a newborn. If there is no surfactant, they collapse, or they really don't collapse, they cannot inflate, and there is atelectasis. Okay, so that's just a continuation of our Laplace law. Another thing that I wanted to talk about is pregnant women and respiration. So in pregnant women, obviously we see estrogen increase, progesterone increased. And estrogen and progesterone both is responsible for increasing respiratory center, increasing the activity of respiratory centers. And that's why we see alkalosis in pregnant women, because they're always increasing respiratory center. Okay. In pregnant women, sometimes we also see AV fistulas, and sometimes they show up in the skin, and we call them spider angioma. Not really related to our respiratory system, but kind of related to the whole cardiovascular respiratory system, right? So that's another thing I wanted to talk about. Third is cyanosis. What we mean by cyanosis. Cyanosis and anemia. So let's say anemia is obviously decrease in oxygen content. Okay. Sorry, decrease in hemoglobin content. And cyanosis is decrease in oxygen saturation. Okay, it's going to be cyanosis. Decrease in oxygen saturation. Anyway, so that was my little bit bits and pieces of information here and there that I wanted to talk about. Now let's move on to our next topic on page 561, which is lung volumes. Now one way I remember lung volumes is by using the mnemonic LITER, L-I-T-E-N-R. Okay, I stands for L, obviously, for lungs, I for inspiratory capacity, T is going to be for tidal volume, I is going to be inspiratory reserve volume, and E is going to be for expiratory reserve volume, and R, the last R, is going to be residual volume. Okay, the entire length of when we add all of them up, we get the total lung capacity. And when we just leave out the residual volume, so from the top until here, that we call the vital capacity. Okay, and if we add residual volume and ERV, this is going to be our FRC. Okay, this is going to be our FRC. Now, one thing that's interesting is that we always take FRC, or functional residual capacity, to be 0. So this level is always 0. So whenever we're going down here, we're going in negative volume. Whenever we're going up, we're going in the positive direction. So let's say there is a question saying that there is a patient breathes into a spirometer, and the pressure turns out to be positive 30 HGmm, or millimeter mercury. Okay, which of the following which of the following volumes are we measuring? Is it TLC? Is it FRC? Is it ERV? Is it RV? Blah blah blah. Okay, so we can see that FRC has a value of 0, but this has a positive value, so that's not going to be the answer. ERV is going to be a negative value. Residual volume is going to be a negative value because it creates a negative pressure, right? Um, Whenever we're expiring, it creates a negative pressure and kind of that negative pressure draws air into the lungs. So that's why we take at FRC, we take the pressure to be 0, and as we go down, the pressure goes down. So none of this is going to be the right answer. The right answer is going to be TLC, because when we do take the total lung capacity, there is the positive pressure inside the total lung capacity. So in this case, the answer is going to be TLC, or total lung capacity. Some other things which are also interesting about our lung volumes is in COPD. We're going to talk about COPD a little bit extensively here. Let's say they give you a graph like so. Let's say they say this is lung volume, okay? And on the x-axis we have time, okay? And then they say that, let's say the black curve is for a normal patient, and let's say the green curve is of our patient. So which of the following volumes is going to relate to our patient, to the patient, not the normal patient? So let's say one is FEV by FVC, the other is residual volume divided by total lung capacity. Now FEV, FVC, that is all good and dandy, okay? That is in a restrictive lung disease, okay? For example, ARDS or pulmonary fibrosis. So that is really not the correct answer, and we can clearly see that the volume of the lung has gone up in general, okay? So that usually happens in COPD when the residual volume compared to the total lung capacity is up. So in this case, the answer is going to be the second option. So that's another thing about COPD. Other things about COPD that I want to talk about here is in COPD, vital capacity is decreased, okay? And it makes sense because what did we say vital capacity was? Vital capacity is everything but residual volume. And residual volume is going to be increased, and we just talked about that. Another thing, this can be confusing, so that's why I'm stressing on it. Another thing that can be increased is going to be ERV. So ERV is going to be increased. But this is the thing, vital capacity is going to decrease, and you're going to say, yes, ERV is part of vital capacity. But in comparison, vital capacity is going to decrease and ERV is going to increase. But even though ERV is increased, it's just the volume that's here is increased. Really, the capacity to expel air is decreased. Even though the volume is increased, the capacity to expel that air out of the lungs is decreased in COPD. Okay, so ERV is increased in COPD, residual volume is increased, but the capacity to expel the air is going to be decreased. Now let me see if I can explain that in a little bit more detail. So in COPD, the radius of the alveoli is going to be increased due to thickness. The thickness is going to be increased, so the radius is going to be increased. Due to increased radius, there is going to be increased in resistance. So resistance is also going to increase. And due to this increased resistance, the ability to expel air out of the lungs is going to be decreased. So air flow rate is also going to be decreased because all of these are going to be increased. Now let's talk about elasticity and compliance. What's going to happen to elasticity and compliance in our COPD patient. Elasticity is going to be decreased and compliance is going to be increased. And this phenomena is just going to be the opposite in a restrictive lung disease. In restrictive lung disease, elasticity is going to be increased and compliance is going to be decreased. And let me see if I can explain it. In COPD, what's happening? The volume is going to be increased and compliance is going to be delta V by delta P. So if volume is increased, compliance is increased. And if compliance is increased, elasticity decreases, right? So that's for COPD. So I remember one and I can remember the rest in a Ziffy. So that's another tip. Sometimes I get confused with elasticity and compliance. I just think they're the same thing, kind of. They deal with the same concept, but they're a little bit different, right? So that's my take on COPD. Other things that I want to mention about COPD is in a patient with severe COPD. Okay, let's first talk about a normal patient. In a normal patient, what is our respiratory drive? Our respiratory drive is by really carbon dioxide in our brain. Okay, so if we don't have, let's say our oxygen drops, then the carbon dioxide level is going to be increased, and this is going to stimulate our brain, and it will tell our brain to breathe more because that's how the respiratory center gets stimulated. So this is in a normal patient. Now, what happens in a patient with an extreme COPD case? What happens in an extreme COPD case is that they are so used to the high volume of carbon dioxide that if you give them supplemental oxygen, okay, if you give them supplemental oxygen, what's going to happen? Their COPD level is going to drop, right? And you might think that, you know, the carbon dioxide dropping is not a bad thing, but this COPD patient is so used to such high levels of carbon dioxide, and when the carbon dioxide level dips, their respiratory drive is completely shut down. As a result, they're going to stop breathing. COPD patient is going to stop breathing if you give them supplemental oxygen. So you have to be very careful with that. Now, the last thing I want to talk about is, let's say, they give you this lung volume curve, and this is not, by the way, this is not anything to do with COPD. I've talked about COPD. I'm pretty much exhausted that topic. So let's take a different point of view. So let's say they give you a normal lung volume graph like that, a spirometer graph, and let's say they give you A, B, C, D, different values, and they say at what level is the pulmonary vascular resistance going to be lowest? What would be your response? And the answer is going to be B, because B is our FRC. And I'll tell you why B is the correct answer. Whenever we are inspiring, okay, and I talked about the pressure. At FRC, our pressure is really 0. Whenever we're inspiring, what's happening? There is increased, whenever we're inspiring, there's increased flow of air inside the lungs, and that increased airflow puts pressure on our blood vessels, and the blood vessel has to shrink, kind of, right? Vasoconstrict, not vasoconstrict, there is pressure on the blood vessel, really, because of increased pressure in the lungs due to incoming air. So it cannot be anything which is in the inspiration. Now you can say, then what about expiration? When we expire, there should be less pressure. But when we're expiring, okay, we're letting air out of the lungs. What's happening to our vessels? So what the alveolus is, now alveolus has more room to expand. So the expanding alveolus is going to put pressure onto our blood vessels again. As a result, this will again put pressure on our blood vessels. So the best time to pick where the pressure is going to be lowest is at FRC, where there is no inspiration or expiration going on. So that's why the lowest pressure is going to be at FRC, which is our B value in this particular diagram.